my qualifications for talking about this topic are, bottom one? Okay. That I actually study thinking in Parkinson's disease, and I do it through brain imaging, but that has led me to think a lot about what causes thinking changes in Parkinson's disease. My research is funded by the VA, and the Department of Veterans Affairs nationally. I'm not really going to talk about that very much, but it is the foundation of what I know. So we've all experienced that Parkinson's patients have two types of symptoms. They have the motor symptoms, meaning the tremors and the slow movement and the difficulty with walking. And so this disease was first diagnosed based on those motor symptoms. But now we're starting to recognize that patients also have a lot of symptoms that we call non-motor symptoms. And those are things like subtle issues with thinking, emotional changes, increased anxiety, a tendency towards depression, can be pain. There are sleep disorders, and the most characteristic sleep disorder of Parkinson's disease is the REM sleep behavior disorder, in which persons may tend to act out their dreams while asleep. But there's also an increased incidence of sleep apnea, breathing problems at night. So there's a lot with the sleep. And then problems with blood pressure regulation and drops in blood pressure when moving from sitting to standing. And that's also a non-motor symptom. So I'm going to focus on the thinking symptoms and to some extent the emotional symptoms in terms of the hallucinations, but I'm not going to talk very much about the depression or anxiety symptoms. So when we see patients in the clinic, we try to characterize what part of their thinking has changed. And the neuropsychologists may do a battery of tests where the person sits down and goes through a bunch of almost like crossword puzzles, a bunch of different ways to quantify how that person's thinking is in comparison to the population as a whole. And the cognitive changes that people experience can be in different what we call domains. So one of the domains would be memory, and that's can I remember the appointments that I need to go to? Can I remember something that happened to me last year that was important to me? So that's memory. Then there's attention, and that's can we focus on what we want to think about, what our will would like us to think about. And if we have problems with attention, that trickles down to memory and other functions of cognition because the information never really got in the first place because we weren't paying attention. So another domain is the executive function. And that's what makes us essentially human. So it's how do we plan? How do we decide what we would like to do? How do we plan what we would like to do? And then how well do we stick with that plan? So abstract reasoning, decision making, and the very higher order thinking skills that we have. And this is the area where Parkinson's disease patients often had changes in the executive and attention areas and a little bit in the memory areas. But the people who really have a lot of problems with memory are Alzheimer's disease patients. So whereas a Parkinson's patient early on is going to have trouble with attention and keeping on task and doing multiple things at once, an Alzheimer's disease patient doesn't have as much trouble with those things, but they just can't remember what just happened. So they can't form new memories. So this is really small. You probably can't see the writing there. This is a study that was done by, I think, Milosevic et al. And they looked at patients who had just come into the clinic with Parkinson's disease being diagnosed for the first time, and what parts of their cognitive function were slowing down according to those domains that I was just showing you. And what they really found is that the psychomotor speed, so processing speed, and this has a lot of effect or some effect on executive function, but we all, or many of us, have had the experience of talking to a person who has Parkinson's disease and asking them a question and then waiting what would seem to other people to a reasonable amount of time to see if they're going to answer a question, and then they don't. And then we go on to the next thing, and then they say the answer to the question. So there's a big delay between the input and the processing and the output, but those people are usually all in there, and they're doing that processing. They're just doing it slower than a person who doesn't have Parkinson's. And then this big area is the area of executive function, and the executive, yes, Irv?
It sounded almost like the idea of breaking through trying to cross the threshold. I was wondering, does it trigger the answer by going on to something? Is it just a matter of time?
Well, I don't know if anyone knows. So he is asking, so what's the mechanism of a person being able to answer the question once someone goes on to the next thing? And he's wondering if it could be that, like when we're trying to step over a threshold or something, if there's a line on the ground and we have a target, it's easier to step over that. So there's an external stimulus. So he's wondering if that problem with answering might be triggered even by going on to the next topic. Maybe. So I think I went backwards by mistake. So here's one of the tests that we might use to test the executive function. This is the Stroop task, and this is a good old test invented by somebody named Golden that it's been around for a very, very long time. And what happens in this test is that first we give the patient these X's here, and they need to tell us the color of the X's. And it's a timed test, so we see how many of those X's they can tell us in a certain amount of time. So here the answer would be blue, red, faint yellow, orange, green. So now the next part of the test is the reading test. So there we have these words, and they're color words, and they're not printed in any type of color. So this would be blue, red, yellow, green, orange, red. And you see I can almost, being a literate person, I can almost go faster on the reading than I can on naming the colors. And then the third part of the test is this one. So the instruction here is look at these words and name the color of the ink, but don't say the actual word. So let's see if I can do it. So red, yellow, orange, blue, green, blue. So even after being on call, I can go through. But did I do it as quickly as this? No, I could not do it as fast. And the reason is because I have to inhibit, when I look at this, my brain wants to read those words, but I have to put something in there. My executive function has to go in there, and it has to say, don't read those words, look at the color and name the color. And so if I slow down a lot when I'm trying to do that, then it's very difficult for me to do that executive function task. So these are the type of tricks that we use to measure changes like this. So when there's problems with thinking and cognition, it's now recognized that there's kind of a transitional state. So between what we call cognitively normal or healthy brain and dementia. So dementia is when a person has enough cognitive problems that they can't carry on their activities of daily living at the same level as they could previously. So they can't, for example, hold the job that they used to be able to do. They might need someone help them with their finances. They might need someone more help in their home. So that's pretty severe cognitive impairment. And then there's this other state, which is mild cognitive impairment. And a lot of people fall into this range, and that means that they have a little bit of trouble with thinking, but they're able to compensate by using lists or taking more time, but they could still do the same job that they did before. So a lot of patients will have this mild cognitive impairment. So now, shifting gears, I want to talk about what in the Parkinson's disease brain would affect the executive function processing. And so this is kind of sciencey, and I'll try to make it comprehensible. So if we are an organism in the environment, we have to take in information from the environment. So we have our vision, our hearing, our smell, and our sense of touch, and this gives us information about the world. And then that goes into the brain, and then we create a picture. We have these sensory processing areas, which are a little bit different areas in the brain. We create a picture of what the world is like, what we think the world is like. So this is like our theory of what it looks like. And so if this information is not right, or if our processing ability is not right, then the picture that we're getting might be distorted or might be incorrect. And so that's the sort of thing that could lead to hallucinations or other distortions of reality. Then when we get that picture of what's happening in the world, this is, of course, biased by a lot of emotional inputs. So if we feel like our sister-in-law, you know, she always does a thing to us that we just hate, and so she's calling us about a party on Saturday, and that emotional input is going to go in there, and it's going to influence this picture about what we think is happening, and our response is going to be influenced by the emotion as well. So then this sensory information goes to some higher order thinking areas, the executive areas in the brain. And it gets processed along with the emotional inputs, and then the organism will make a decision, and then there will be a behavior or a thing that the organism does as a result of that. So it might be like having a facial expression. It might be deciding to go to bingo on Saturday. It might be getting up early enough to go to work on time. So that's the result of all this. And if any part of this pathway isn't really working right, then it's hard for these outputs to be accurate. And much of this is done by a part of the brain that's called the frontal lobe. So this picture here is a little bit dark, but it's a brain, excuse me, picture from the side. And so this is the back of the brain. The spinal cord comes up here, and then there's the brainstem. And then there are these different lobes of the brain. And the biggest one here is the frontal lobe, the frontal cortex. And that's the part that has most of the executive processing areas. So that's the part that does most of this decision making with the influence of these other inputs. So then there's also a microscopic picture of the brain. And the brain is made up of these tiny cells called neurons. And there's part of the cell that does the signaling at the end. Then in the middle, there's like the wires, the telephone wires. That's the axon. And then there's the cell body, which is where most of the energy and most of the DNA and all that stuff is. So this cell body is like in the gray matter. And this is unfortunately not very big. This is a picture, an MRI of the patient's brain. And on the edges of the brain are all these cell bodies. That's the gray matter. And then deep in the brain may be these connections areas where the nerve cells connect to each other. So the brain has a bunch of circuits which go from the inside, the deep part, out and back down. And it's probably some electrical impulses going around this, kind of like Morse code at their specific frequency that on a crude level is how we think. So there's an important part in the deep in the brain, and that's the striatum. And I have some bigger, better pictures later on, but this is what loses the dopamine input in Parkinson's disease, and so it affects those circuits, those circuit oscillations. And the other thing that influences cognition and thinking in Parkinson's disease is the neurotransmitters. So at the ends of these nerves, the way that they make those circuits and the way that one connects to the other is that there's a little tiny chemical molecule here that jumps the gap, and that's a neurotransmitter. And there's a bunch of different kinds of neurotransmitters in the brain, but dopamine is one of the key ones that is lost in Parkinson's disease. So here are the names of some of the other neurotransmitters. There's also acetylcholine, and that one is particularly affected in Alzheimer's disease. And then serotonin, which many patients take antidepressants, and those often affect the serotonin. So serotonin has a lot to do with mood. And those are those little molecules that jump between cells that do the signaling. So what happens in Parkinson's disease? Well, the nerve cells in the substantia nigra die. Are you guys familiar with that? Okay, so if we look at a cross-section of a normal person, there's this black substance, the substantia nigra, down in the bottom of the brain stem. And that is where the dopamine is being manufactured. And in a person who has Parkinson's disease, that black area just isn't black anymore because those cells have been lost. And those cells, so when I told you about the wires that are connecting the different brain regions, that those dopamine cells connect up to the striatum. And the striatum is a part very deep in the brain that's bright. On this picture, it looks like a comma. So this is a PET scan, and we're looking as if we're looking up from the person's feet. And the dopamine is this bright area. So the substantia nigra makes the dopamine, goes up to the striatum, and then lights up the striatum. So you remember I was telling you that the striatum is heavily connected with a lot of the thinking regions in the brain. So those thinking regions would be in the frontal lobe, as I was showing you. So this big thinking area in the front of the brain has a lot of those circuits that go through the striatum. So you could imagine that when we lose the dopamine input to the striatum, it affects not only the communication with the movement areas in the brain, but also some of these thinking areas. And some of them do the executive function, so they do regulation of behavior and decision making and things like that. And then some of them actually even do motivation. So especially down in the bottom of the brain here, there's some motivation areas. So you can imagine that if you lose some of the dopamine going to those areas, you might have a little slowing of your mental processing, and then you also might have some problems with your motivation. So the other thing is that if we give the medication for Parkinson's disease, and one of the classic medications is levodopa, and when you take the levodopa, which is in Sinemet, it goes into the brain and it gets metabolized into dopamine. But since you've lost these dopamine inputs, the natural dopamine inputs to this area, we're just pouring that dopamine all over the brain. So some of these circuits get the right amount, and that helps the tremor and it helps the movement and things like that. But because the loss of dopamine in the striatum is uneven, some of the other circuits might get a little overdosed. And so when those areas get overdosed, then we can have problems with motivation. So the person might be way too motivated and want to do something way too many times. Or they might have hallucinations. So it's kind of that our medications are a bit non-specific. We can't target exactly the area where the dopamine is lost. So any questions about that?
So I guess what you're saying is that the carbidopa-levodopa efficiently replaces what the brain is not manufacturing?
Yes. So carbidopa, well, I don't know if it's sufficient. It's sufficient to overcome his question is, does carbidopa-levodopa replace the dopamine that the brain is not making? And the answer is yes, but it's not a perfect replacement because it's not going to exactly the part of the brain we want. It's going to everywhere in the brain.
How long can that continue?
It can continue forever, but we do know that on this picture, as these little nerves here in the Substantia Nigra are lost, so initially in the early stage of disease, these nerves take up the carbidopa-levodopa and they turn it into dopamine, and then they keep it and they let it out in the striatum in a way that is physiologic, that we would like to have it, that would happen in a normal person. But then as more and more of these nerves are lost, then when we give the person Sinemet, those nerves can't keep the Sinemet and let it go at the right amount. So it becomes more like just having it in the blood, and it just stays in the blood for as long as the half-life of the medicine is, which is a few hours, and then it's gone. So because it can't be stored in these cells anymore.
So, could you repeat what you said, that the medication gets poured into the brain and then it can result in hallucinations or
So when we give the medicine, we can't specifically decide what part of the brain it's going to go to. It's just in the blood, so it goes everywhere. And so in the areas that don't have enough dopamine, like the movement areas, those get really helped by it, and the patient's able to move better. But possibly because other areas have kept more of the natural dopamine, then they can get a little bit overdosed.
So it's too much of that drug that is causing the
It's enough to make the patient move correctly.
right, but the hallucination is because
Can be a side effect, yes. Yes, can be a side effect.
everyone's going to have a hallucination. I don't like the way that they talk about it, how it's like commercial.
Yes, so she doesn't like the New Placid commercial where they talk about, it seems like everybody, it implies that everyone will get hallucinations. Yeah. She doesn't like the commercial on television that suggests that all Parkinson's patients will eventually get hallucinations. It's misleading. Yes, Irv?
Is the gas can look like it became
So the gas can, one of our good old colleagues, Dr. Erwin Montgomery, used to use this analogy. So if this Volkswagen were trying to make it go and we're giving it levodopa, it's like pouring gas all over the car. So we're not determining exactly where it goes. So that I have to attribute that to him because he's the one that actually said that. I don't think that the analogy is that literal. All right, so we've talked about some of the scientific reasons why there might be these subtle cognitive changes in Parkinson's disease, and some patients less subtle. So some are changes in the way the brain circuits with the frontal lobe work due to the loss of dopamine. And the other reason is changes in neurotransmitter levels. So patients will lose not only dopamine, but also acetylcholine and some of the other transmitters too. I keep going backwards. There we go. Okay, so what types of cognitive difficulties might you observe in a person who has Parkinson's disease then? So one thing would be difficulty with multitasking. So part of the executive function network is the working memory. And that's like if I have to cook Thanksgiving dinner, and I've seen some people that are really good at this, and I'm not very good at this, but they'll have the sauce that they're preparing over here, and then they'll be putting the turkey in the oven, and then they're starting in cranberry sauce, and they got a timer for that, and then they got to go back over here, and then they got to not leave the refrigerator open, and all that's multitasking. That's like, you can't really multitask, you can't really pay attention to multiple things at once, but you can switch in between things. And so that multitasking, so that will probably become harder for you if you have Parkinson's disease, not inevitably, but due to the effect on these circuits, it's likely. So then perseveration, so a tendency, I was saying how parts in the bottom of the brain, the motivation centers might get a little overdosed, and that might make people a little obsessive, and so they tend to focus on something and they have trouble switching to a new thing. And this is all a generalization. It might not be you that has these issues, but if you see them, maybe in other people. So slowing of the mental processing, we talked about that. And then impulsivity. So a lot of what happens in those circuits is that it's our internal sense of timing. And so that gets a little bit distorted in Parkinson's disease, and they don't actually have control over the frequency at which they do something. So they might have to choose to do it when they can, when that circuit comes around and when they can do it. And so they might actually do some things faster than a normal person would do it. So if we have them tap their finger or something, that tapping might be small, but it also might be very, very fast. And that's kind of, or their speech might be fast. That's impulsivity. And it's also a problem with these circuits. So what other emotional symptoms do we see? Well, apathy, so less interest in participating in especially difficult activities or activities that require extra effort, novel activities. Increased anxiety, and some patients with Parkinson's have anxiety, severe anxiety, for a long time before they ever develop the disease. Depression is more frequent, and then we'll talk about the hallucinations and repetitive and impulsive types of behaviors. So one syndrome that not everybody develops, but some patients with Parkinson's disease do, is called the dopamine dysregulation syndrome. So especially patients who've had Parkinson's disease for a while, and they're taking carbidopa, levodopa, and they're pretty used to having their doses when they're used to having their doses. And they, because of those cells being lost in the substantia nigra, they start to be pretty sensitive to when the medication stops working. And they might even feel anxiety when the medication wears off. And so they become a little bit of dopamine overusers. So they might increase their doses of carbidopa, levodopa, or they might take them more often. And a lot of times those people who are afflicted with this dopamine dysregulation syndrome also have a lot of dyskinesia, dopamine, which is an evidence of the too much Cinemet sometimes, not always. But it often happens to people who respond very well to carbidopa, levodopa in terms of their movement symptoms. So they can get these mood fluctuations where they feel really, really terrible every time the medication wears off, and then they really want the next dose. And if they live in a facility where they have to call someone to bring the next dose, then that becomes a big point of contention, and they just feel bad. So, and then there are some even more significant compulsive behaviors like gambling, binge eating, or compulsive shopping that can be influenced also by the dopamine medications. So I'm hoping this video is going to play here. So one of the videos that was made by the Movement Disorder Society is of some Parkinson's patients. I don't know if it's going to work. So luckily, that's my only video. So this is a video of a couple of women who have a condition that's called punding. And that's something that was first described in persons who were cocaine addicts. But it's also sometimes people who take a lot of levodopa and have this dopamine overuse syndrome. And so they may engage, especially late in the day, in some types of behaviors that might seem sensible in another context, but they kind of just take it overboard. And so this video is showing a woman who's sorting her button collection, and she has thousands of buttons, and she comes home at night, or most of the day maybe as well, and she's moving these buttons into these different bins, and she does this so much that she isn't perhaps spending time with her friends, she isn't getting out of the house, she might not even be eating as much as she would normally. So that type of compulsive behavior, and sometimes in response to levodopa, can be something that occurs in Parkinson's disease. So what about hallucinations? Yes. So what about so hallucinations are common, and they are common in patients even who have very early Parkinson's disease who don't have much in terms of cognitive issues. And sometimes when we're throwing a lot of medication at someone trying to make their tremor better or trying to make some specific part of their symptoms better that they would like, we can get the side effect of hallucinations. And it's important to be sensitive to this symptom because it can get out of control. And usually we want to make note of it, and especially if it starts moving in a serious direction, we want to take action on it because it can get difficult to manage. So initially, a person may just feel like there's someone in the room or someone watching them, that they don't look over there and there's nobody there, but they just have a feeling of presence, it's called. And then the next stage of developing hallucinations is to see things, to distort objects that are really there and think that there's something else. So if I started thinking that this lectern is, a tall bear that's standing there, and especially in low light or at the end of the day, it looks like a tall bear, but then in the morning, it looks fine, it looks like a lectern, that would be sort of a visual illusion. And then those may evolve to be more severe, and then I might always see that lectern as a bear, but I know it's not a bear. I know it's a lectern, but it looks like a bear to me. So that's a hallucination with insight preserved, and usually, again, that's not that troublesome. But then oftentimes patients tend to eventually lose insight into the fact that those are hallucinations, and then they may act upon them. And the hallucinations in Parkinson's disease are very often visual hallucinations. And they're often visions of people and people they know. So sometimes they see children crawling around on the floor, or they see someone visiting who wasn't really there, sitting in a chair in the room. Those are the sort of typical things that people describe. And it can become problematic. So I had one patient who was living with his son, and he was taking a fair bit of carbidopa, levodopa, and he would look out the window at night, and he saw a bunch of people on his property. And so he'd call the police. And the police would come out, and they'd check out, and there's nobody there. And then the next night, he sees the people on this property, he calls the police. So then, it becomes a bit of a problem, and then pretty soon that patient can't live independently because he keeps calling the police, and his family's trying to figure out how to deal with this. So it can be a problem, and that's why we usually pay attention to it and try to start a treatment or decide what to do about it fairly soon. So what are the risk factors? When do people usually or experience hallucinations in Parkinson's disease? Well, not everybody experiences hallucinations, but having the disease for a long time is a risk factor. Having dementia or other significant cognitive problems is a risk factor. Having sensory impairments, so trouble with vision and trouble with hearing, those predispose to other distortions of reality. And this is very important because this is one of the things we can intervene about. We can improve people's sensory experience, and that can reduce the tendency towards having hallucinations. Poor sleep is a problem that can also be addressed. The dopamine agonist medications is listed, but just because it's been studied, there's actually quite a lot of several of the medicines that are more likely to cause hallucinations. And then some genetic factors that are just investigation. I'm gonna get to that. He says, which medications cause more hallucinations? And I have a slide about that, so I'm going to talk about it in a minute. So what causes hallucinations in non-Parkinson patients? Well, sensory deprivation is one of the things. So if a person is going blind from retinal degeneration, they may see villages, and there's often hallucinations as a side effect with that. People with hearing loss can have auditory hallucinations. So that's a common cause. Psychiatric diseases, depression, schizophrenia are often associated with hallucinations, but more frequently, sometimes visual hallucinations, but a lot of them are auditory hallucinations, meaning hearing. They hear things that aren't really happening. Hallucinogenic drugs, LSD, others. So interestingly, in our culture, we think that these hallucinations and being out of touch with the reality is generally a bad thing. But many cultures have even sought to induce hallucinations as a view of a pathway to communication with the divine. So the Native Americans who would fast or take peyote and then receive instructions or other information that they viewed as coming from a higher power, and it's not exclusive to that culture. Many cultures have. So the fact that we think of it as a sign of infirmity is maybe a little bit, reflects our worldview a bit. Delirium is an important cause of hallucinations, and this is in patients often who are in the hospital and have some other severe medical illness, and those patients will frequently lose touch with the reality and may begin to hallucinate. And then grief, so after a person passes away, it's not uncommon for relatives or friends to see hallucinations or visions of that person having been present. So schizophrenia is very interesting because it has also relations to dopamine and other neurotransmitters in the brain that are also affected by Parkinson's disease, but it's the opposite. So there's too much dopamine signaling. And schizophrenia occurs mainly in people in late teenage years or early adolescence who develop hallucinations, delusions, odd thinking patterns, and difficulty holding jobs, severe depression, risk of suicide. And they, like Parkinson's patients, interestingly, have positive symptoms, which are the hallucinations and delusions, but they also have negative symptoms. So they have a lot of problems with apathy, social withdrawal, odd thinking patterns that make it difficult for them to function in society. And so many of the medications that we have used for hallucinations in Parkinson's disease are some of the medicines that were developed to treat schizophrenia and reduce hallucinations in schizophrenia. And interestingly, those medications are quite effective for the positive symptoms for the hallucinations, but they're not as effective for the negative symptoms, the apathy, the lack of motivation. Those things are harder to treat. So these medications are known as the antipsychotic medications, and we do often end up using them in patients who have Parkinson's disease, who have hallucinations. So I talked a little bit about delirium. That's another cause. And then many of you have probably heard of Lewy body dementia. So if a person with Parkinson's symptoms develops a lot of problems with thinking and even dementia early on, and often hallucinations, then they may have a cousin of Parkinson's disease, which is Lewy body dementia, rather than Parkinson's disease. So what's our medical strategy when we have someone who's starting to have those threatening or out of touch with reality types of hallucinations? Well, first of all, we want to make sure that the person doesn't have delirium. So if they had a fever or something, we would look and see if they have pneumonia, have some other type of physical problem going on that would tend to tip them over into having hallucinations. Then we get rid of those anti-Parkinson medications, which are bad actors, and I'll show you those on the next slide. And then we think about treating with one of these antipsychotic drugs, or there's another one, donepezil. So donepezil was developed for Alzheimer's disease, and it improves acetylcholine in the brain, one of those neurotransmitters I was showing you. And so donepezil has been useful for hallucinations in Parkinson's disease, but it's a relatively modest effect. It's not super strong. Then we often turn to these other medications, the antipsychotics, and the ones we specifically tend to use in Parkinson's disease are quetiapine, clozapine, and pimavanserin and Nuplazid that you've seen the ads for. So these are special antipsychotic agents. So I had mentioned that early on for schizophrenia, the medicines that they developed were just mainly block dopamine in the brain. And those were the high-potency antipsychotic agents like haloperidol or Haldol. And those medicines make Parkinson's disease a lot worse because of their effect on reducing dopamine. So these drugs, which are newer, they're a third-generation antipsychotic agents, their effectiveness is actually more through some of the serotonin pathways, a different neurotransmitter system, and so they don't tend to make Parkinson's disease worse the way some of those old classical schizophrenia medicines did. So I'll talk about that too. I probably should have put that, I think it's on a later slide. So here are the medicines in Parkinson's disease that are more likely to cause hallucinations. So amantadine, really useful for tremor, very useful for Parkinson's symptoms in some patients, but it can really cause people to hallucinate in some situations. Trihexyphenidyl. So these two medicines reduce acetylcholine in the brain, and that seems to really precipitate hallucinations in some people. So usually we get rid of those first, and then the next one we think about getting rid of is the dopamine agonist medication, so pramipexole, ropinirole, or rotigotine, the Nupro patch. So these are also worse than carbidopa-levodopa as far as causing hallucinations. Okay, this one is Symmetril, and this one is Artane, and this one is Mirapex and Requip and Nupro. Yeah. And then sometimes we get rid of these monoamine oxidase inhibitors like rasagiline or Azilect, but they don't really usually have a big effect. And so we try to get the person on a simple regimen of carbidopa-levodopa, usually just Sinemet for their motor symptoms, and then we try to minimize the dose of that. And that's the best regimen for them to probably reduce their hallucinations. Yes? So they're the same thing. Sinemet. So she's asking if Sinemet and carbidopa-levodopa are the same thing, and the answer is yes. So that's the brand name. Sinemet is the brand name for carbidopa-levodopa. Yes. I think that there are side effects. So he's asking, he said, I mentioned that the hallucinations are side effects, and if they're not side effects of the medication, what are they side effects of? Is that correct? Are they always side effects of the medication? So the answer, we don't know, because a lot of patients have been treated for Parkinson's disease with these medications, and most patients need to take some of them. But it appears that in advanced stage Parkinson's disease, some patients may develop hallucinations even without any medicine. So they're not necessarily induced by the medicine. What is considered a simple carbidopa-levodopa regimen? Something like 25/100, 2-3 times a day, or 2 every 3 hours. Yes? So does using carbidopa-levodopa or other medications early on impair your use of carbidopa-levodopa later? Heavily. If using it heavily early on changes your ability or effect later. Not that we know of. We know that treating early on induces dyskinesia, so the side effect of excess movement, but we don't know of it causing other harm. So there you go. There's pimavanserin and our Nuplazid. So this is the one that you're seeing heavily advertised on TV. So that's in medication that's FDA approved for use in Parkinson's disease with hallucinations. And the studies that they looked at this medicine, they were using a positive symptom scale. So I talked to you about the schizophrenia and Parkinson's having positive symptoms and negative symptoms, and here the positive symptoms was the hallucinations. So the people who took it for 6 weeks had more improvement on that symptom scale than the people who took the placebo. So we don't know if it works better than the other medications that we can use for hallucinations that have been around for a longer time. We don't know if it works better than quetiapine or clozaril. And in fact, my clinical impression is it does not. So it is a good choice, perhaps, early on with hallucinations, but it's not very dose adjustable, and those other older medicines that we have work fine. Now, the problem is that probably the best one is clozapine for hallucinations. It actually can improve tremor. It can improve some other Parkinson's symptoms. It's not too sedating in most patients. But this medicine has problems with affecting the blood counts. So in a few patients, it caused severely low blood counts that did not recover. And so when a person takes clozapine, we have to monitor their blood counts every week for a long time, and then forever for every month. Yes? Clozaril, yeah. Clozaril is the brand name for clozapine, and the brand name for quetiapine is Seroquel. Yes. Yes.
Is Nuplazid ever going to come down in price?
Well,
Can anybody afford it?
nobody can afford it. Most insurance won't pay for it. So when the new medication comes on the market, it is under patent, right? So they can charge whatever price they want to charge for it for the first 7 years or whenever it's under patent. Then it goes off patent. So then often what the pharmaceutical companies do is they turn it into an over-the-counter preparation because they can repatent and rebrand it as an over-the-counter preparation. And then they also offer the assistance program sometimes to get you started on one of these medications, but then you've always got to ask, is that assistance program going to continue for the duration I would need to take this medicine or not? Yeah.
I was told it's $3,000 a month, is that true?
Yes,
How much? Okay.
it's a lot.
That's a lot.
Yeah.
What drug is $3,000 a month?
This new Nuplazid. Yeah. So we talked about to deal with a person who has Parkinson's, who's developing hallucinations. We talked about how to change their medications for their motor symptoms, how to maybe just go only to Sinemet, carbidopa, levodopa. And we talked about possibly having to give them an antipsychotic medication like the quetiapine or clozapine or Nuplazid. But what can we do about their environment to make it easier for them to cope and to make their brain better able to suppress those hallucinations? So one thing that we can do is work on their sleep. So a lot of patients get problems with sleeping more during the day and being up at night and not having good quality sleep. So evaluating their sleep and trying to improve the quality of nighttime sleep and get everybody the number of hours they need a day is one thing that would be a goal. And then address the sensory loss. So I talked about the hearing and vision problems. If the patient needs hearing aids or a pocket talker, then they should have that. If they need glasses or something to address their vision problems, do the best you can with that. Then mobilize them. So if the person can get out of bed safely and walk, or if they need a walker, just getting up and around is going to start to repace their brain and get their brain back in normal gear. And then try to provide stimulation during the day. It may not be realistic for you to sit next to the person and have them do crosswords all day, but maybe they could go to adult daycare, or maybe they could do projects, or maybe you could get them involved in something that keeps them awake and keeps them thinking. So keeping people in a familiar environment is also helpful, and it's often when they get into a new environment like a hospital room or the family takes a trip or something that there's more problems with these cognitive and behavioral symptoms. So trying to keep them in a familiar environment where things are predictable will help. And then try to communicate with them, realizing that it's not the person talking when they're having a lot of fears and concerns and paranoia and obsession. It's their disease. And so try to remove yourself from being personally responsible for that situation, and if you can, fighting with them. And try to communicate with them simply as you can, with simple goals and one-step procedures. And then I did want to talk about, there are also some medicines. These medicines are not for hallucinations, but they are for thinking problems, and most of them have been developed for use in Alzheimer's disease, but we do use them in Parkinson's disease. So you may hear of them. One is rivastigmine or Exelon, one is donepezil or Aricept, one is galantamine or Razidine, and then one is memantine or Namenda. So some patients do benefit from these medicines for their thinking and cognition. Usually the effect is not super strong, but it does help. And then as we do more studies of patients who have these types of disorders of the brain, including Alzheimer's disease and Parkinson's disease, we realize that There are many non-medical interventions to improve health, such as exercise, physical therapy, improve sleep, and all these things will help with cognition and function. So what are the things that you can do if you have, say, what I was talking about before, the mild cognitive impairment? So what if you have a little bit of trouble, maybe some mild cognitive changes related to your Parkinson's disease? How can you deal with that? Well, so thinking about those brain circuits and the difficulty with executive function, here's some of the things you can do. One of the things is do things one thing at a time. So don't do that multitasking. If you're cooking the Thanksgiving dinner, get someone to help you. Don't try to do it all at once. Try to focus on one thing at a time. Break tasks down into steps and avoid distractions. So if you're driving, don't have the radio on, don't have the kids in the back, try to avoid things that are going to distract you from doing what you're doing and that are going to challenge your attention. Providing external cues, as Irv mentioned, might be very helpful. So some pacing strategies or writing out step-by-step instructions, step-by-step plans. Try to remain calm, because when any of us get anxious, then basically we shut down a lot of our brain that does the thinking, and we get into the fight or flight mode, and then we can't really think very effectively. So try to remain calm, even if you're getting frustrated. Take breaks to monitor progress. So halfway through your project, did you get to the stage that you wanted to? Are you doing it in the order that you wanted to? Think about it. Try to stay on task. And then there's a whole field of cognitive rehabilitation, which is available through, I believe, the UW Health Middleton Clinic with some of the occupational therapists, of working on learning some of these strategies to improve thinking function. And they are effective, so they have been shown to improve performance in people who have mild cognitive problems. So that's all I had. Thank you for listening.